Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our webinar series on the medical and public health considerations of COVID-19. Today, we have a very timely webinar on COVID-19 vaccine update, pregnant women, children, and variants. Next slide. I'd like to thank our webinar series partners for passing out the word about our webinar series, much appreciated. Next slide. This webinar will be recorded and will be available on our website within 48 hours. All the registrants will get an email about the hyperlink once it appears up on our website. Next slide. We also have developed a series of FAQs on a variety of some of the previous webinars, and this can also be accessed on our website. Next slide. There will be a Q&A at the end of the webinar. Please type your question into the Q&A function during the webinar, and we will get to as many as we can. We monitor all the platforms. Occasionally, we'll go over the top of the hour by a few minutes, depending on the webinar queue. Next slide. I'd like to welcome my co-host and moderator today, Dr. Andrew Stolbach. Dr. Stolbach is a board member of the American College of Medical Toxicology and is a professor of emergency medicine at Johns Hopkins University in Baltimore. And thanks, Andrew, for joining us today. Next slide. Well, it is my great pleasure and privilege to introduce our speaker today. We started this webinar series back in March of 2020, now some 15 months ago. And Dr. Anderson has been kind enough to share his expertise with us, not just once or twice, but this will be the third presentation from Dr. Anderson. We initially brought him in to speak back in the spring of 2020 with an initial update about vaccines months before the first vaccine hit the public. And he's been in the forefront of being a co-PI on vaccine work done at Emory University. And as a pediatrician has been particularly interested in the rollout of the vaccine to the younger age groups as well. The data that he's going to present today really is cutting edge, the current word about the progress that's been made over the last 15 months. So I'm delighted to introduce Dr. Anderson, who's a professor of pediatrics and medicine at Emory University School of Medicine and is an attending physician at the Children's Healthcare of Atlanta. Please put your questions into the Q&A, and we look forward to a robust discussion following Dr. Anderson's presentation. Thank you and welcome.
Thank you so much, Paul, for the opportunity to talk with you again this afternoon, and grateful for the opportunity to speak with the group again. So let's see. All right, so here are my listed disclosures. I think most importantly, I'm the PI on the Pfizer pediatric trial here at Emory. I'm also the PI of the Moderna Kid Cove study here at Emory, and then have been involved with both Moderna and Janssen vaccines from phase 1 through phase 3 for Moderna and phase 3 for Janssen. So here's the overview. We'll cover a few more things beyond just the strict initial ideas I had about what to talk about. We'll be in part updating you on vaccine development, the variant and durability of the immune response post-vaccine, provide you a safety update, talk about pregnant women and children. So we'll dive in here. So this is in part why we have issues with SARS-CoV-2. It is our relationship with our animals, and yes, that is a bat that she is kissing there. And the interaction between humans and animal species puts us at risk of transmission across species viruses. And so fortunately, we'd been a little prepared for the possibility of a coronavirus, in part because of the original SARS coronavirus in 2003 and then MERS in 2013, which were identified, and some efforts were made to develop an understanding of the immune response and also the potential for a vaccine in those individuals. Here is January of 2020, of course, the red dots of where COVID-19 was emerging and had spread already by the end end of January. Importantly, and I think this is key in terms of the context for this talk, much of the early data coming from China suggested that children were infrequently infected. Here you can see 0 out of the cases occurring from China. And I think we should have been better prepared seeing these data where you see initially the strong association with the Hunan seafood wholesale market, but then within a period of a couple of weeks, all those cases were primarily occurring outside of known exposure. And then also a number of them were occurring without known exposure to either market or a person with respiratory symptoms. And so this transmission of relatively asymptomatic disease has been a big issue for COVID-19. This paper as well, published very early on, also should have given us insight into the fact that, that SARS-CoV-2 may well emerge and develop resistance over the course of time. Here you can see in a single family cluster, key highlights that occurred is that you see actually amino acid sequence mutation that's occurred in between 2 different isolates within the same family that was infected with SARS-CoV-2. So, so as such, one might expect that variants might well emerge. Of course, over the course of time, we've seen an explosion of SARS-CoV-2. This was May of last year. Fortunately, I think that there had been some real basic science work that had been done, and this is a good example where our investment in basic science clearly has paid off. So this was work done out of NIH that was started pre-SARS-CoV-2 and was finished post. In essence, they had identified that this spike protein was relevant in terms of the immune response against SARS-CoV-2. And what they had done, started these studies but not finished them, was they'd started using a MERS S2P mRNA vaccine in these mice. And in essence, with increasing doses of vaccine, you see increasing antibodies developing post-vaccine. And then they then challenged these mice with MERS, and you can see that animals that received the placebo or PBS lost a tremendous amount of weight, had a tremendous amount of virus in their lungs, and a lot of lung hemorrhage. In comparison, those that received vaccine, you can see that they had relatively little weight loss. Their lung viral load was very low, and they didn't have pulmonary hemorrhage. And so this was provide a lot of the basis for the FDA giving thumbs up on moving into humans before we had animal data with SARS-CoV-2 vaccines because of the data from this and other studies. Of course, there are multiple different vaccine general platforms that one might use to develop a vaccine against SARS-CoV-2. For a number of reasons, the live attenuated and inactivated vaccines, which have been a mainstay of vaccinology, did not move forward into clinical trials quickly. In comparison to the vectored vaccines, did move, the recombinant protein vaccines, and then also the mRNA vaccines. I think a large part of the success in the US was due to the big investment that the US made in terms of trying to expedite a COVID vaccine as quickly as possible. In essence, the federal government decided to essentially purchase 100 million doses from 6 different manufacturers, 2 mRNA vaccines, 2 viral vectored vaccines, and 2 S protein-based vaccines. It purchased these at risk before these vaccine manufacturers had started their phase 3 clinical trials. And fortunately, we've seen Pfizer and Moderna move all the way forward to vaccine licensure. The 2 viral vectored vaccines, the AstraZeneca and Janssen, both have US data. However, it looks unlikely that the AstraZeneca vaccine will move forward to actual licensure in the US. And then the more classic vaccine technology of protein-based vaccine, there are 2 vaccine manufacturers there, Novavax and Sanofi GSK. Sanofi GSK had to go backwards before they can move finally into their phase 3 study, which is starting right about now. And then for the Novavax, they're still awaiting their data to support an EUA in the US. And it looks a little uncertain whether that'll be successful in terms of moving forward. I show you these 3 graphs from the phase 3 clinical trials. On the upper left is Moderna, middle is Janssen, and upper right is Pfizer. Key point here is that right at day 14, you see a divergence happening between those that receive vaccine on the bottom line and those that have received placebo in terms of their case numbers of COVID-19. And you can see right at that day 14 mark across all 3 vaccines, you see a marked difference in terms of the number of cases of COVID-19 occurring. And so I think that's a key point, is that the first 2 weeks really do not provide any protection after any dose of the vaccine, but then by 2 weeks, we see some impact of the vaccine that further is implemented by the second dose for Pfizer and Moderna. This is the current state of affairs. We've got Pfizer, Moderna, and Janssen. Pfizer and Moderna are working pretty actively towards a BLA. Currently, we're unclear about the timeline of when that might occur, and then Janssen is a little further behind. AstraZeneca and Novavax sit right at the end of their phase 3 clinical trials. So there are a number of residual questions that exist from the phase 3 trials, including longer-term safety data in those individuals who've received vaccine. Can the vaccines blunt viral replication and transmission in vaccine failures? We're still awaiting great data about that, but does suggest that the viral load is lower in those that have received vaccine that have breakthrough disease. And then I would expect that we would see additional data about hospitalization and potentially prevention of death from the phase 3 clinical trials. And one of the holy grails of clinical research right now is the correlative protection against COVID-19, which we do hope will come from these vaccine clinical trials. And that'll give us some ability to then standardize across assays and sera, allowing for better comparability and potential to license other vaccines without actual efficacy data. Post-licensure data also looks very good. This is data from Israel with the Pfizer vaccine. And in essence, you can see, again, right at that day 14 mark, in those that receive vaccine through the EUA and in Israel, you can see a marked divergence in terms of COVID cases, and then severe COVID and even death due to COVID. So really remarkable that these vaccines are also working very, very well post-licensure as well. So we'll move on to talking about the variants and the durability of the immune response. So this is data in part that I was a part of looking at individuals who had previously been infected with COVID, and you tend to see higher antibodies in those with severe disease. But the key point here is the RBD titers. And what you do see is that there is a decay, as we expect, over the course of time in terms of your antibody levels post-COVID infection. And the blue line or blue lines here, this is a control population from pre-COVID in red. So the RBD antibodies do decay. Half-life is about 200 days. What was seen then with the Moderna vaccine, and this is a slightly different assay, but I think it's still relevant, is that you do see the decay of antibodies perhaps a little bit more quickly, so about 100 days using the power analysis. So perhaps a slightly faster decay in terms of antibody titers. But then I think this is an even more important study, which looks at neutralizing antibodies. And this is data generated by Mehul Suthar here at Emory, who's one of the leaders in terms of neutralizing antibodies. What you can see is that the half-life for neutralizing antibodies, which we think are likely to potentially correlate best with immune protection, is about 254 days using a power law, which probably provides a little better estimation of the half-life. You can see for Moderna recipients, it's about 202 days. So this is actually a fairly similar rate of decay with neutralizing antibodies, which we think are probably going to be even more important than just binding antibodies. So, and the other key thing is that they're actually starting at a much higher titer. So this is about a log higher titer, almost a log higher titer in those that have received prior vaccine, and the decay rate is fairly similar. So this does provide some reassurance that we're going to have antibodies persisting for some time post-vaccine. Here are data then, and this is again data from Mehul, that looked as well at infected patients acutely, convalescent patients, and then vaccinated individuals over on the right. And the key point I want to make here is that the original emergent vaccine or emergent strain was the A, and B117 is the UK variant. And in essence, you see that there's perhaps a slight drop in terms of neutralizing antibodies against the UK variant But among those that have received vaccine, they're starting at a higher titer. And even though there's a slight decrease, it's still, very, very high titer antibodies. In comparison, the South African strain, which is the B1351 strain, you can see that in general, and this infographic demonstrates things pretty well here. In essence, for acutely infected versus convalescent versus those receiving vaccine, those that receive vaccine start at higher titers, but you do see that their antibody titer with the South African variant or the B1351 strain is a little lower than that of those that have than against the homologous strain or the strain that initially emerged. So this had prompted the decision to move forward with developing some viral variant vaccines here in the US, and both Pfizer and Moderna are actively testing those vaccines to evaluate their immune response. Here's data that my group in Mehul was also involved with, looking at the Indian variant, which is the B1617 variant. And in essence, this is looking at convalescent individuals in terms of their antibody titer against the original strain and then against the Indian variant, Moderna vaccine recipients, and then Pfizer vaccine recipients. And I think a key things here, one is that you're starting at a much higher titer in those that have received vaccine than in those that are recovering from acute COVID. And you're also ending at a higher titer, antibody titer, but you do see about a 7-fold decrease in terms of the antibody binding to the Indian strain. So it is a cause for concern, but certainly not panic. So as I mentioned, both Moderna and Pfizer move forward with vaccine clinical trials evaluating variant vaccines. One of the key things is how well do these vaccines actually work in a real life situation against, say, the South African variant. And this is data versus the South African variant, which is the B1351 variant. Here's actually data from Novavax. And in essence, you see that it is still effective against the South African variant. You see the same thing for Janssen, where most of these cases were the South African variant. And again, you see still very good efficacy. And then in data recently published coming out of Yemen versus the UK variant, which is the top line here, for any infection, you see in essence that perhaps there's a little decrease in terms of prevention of any infection. So 75% efficacy versus about 90% efficacy. But against severe disease, versus the UK variant, it was 100%, and then also against the South African variant. So again, in real life, doesn't always totally match up with the labs. There does seem to be some decrease in terms of antibody response, but we still see a fairly high degree of efficacy, at least in the short term, against these variants. From a safety standpoint, there's of course a lot of safety updates. A couple key things. One is that there's ongoing surveillance happening through the vaccine adverse event reporting system, and then also through multiple other data systems that CDC is analyzing. The VAERS system is helpful in terms of detecting rare safety signals and rare events, but is not actually designed to assess causality. But what it is useful is detecting rare serious events. And so this was data about the risk of anaphylaxis with Pfizer and also with Moderna. I think probably these are not really statistically significant differences. I think the key thing to note is that this is roughly about 5 or 2.5 per million doses administered. And this is actually down into the range of pneumococcal vaccine anaphylaxis. So it doesn't appear to be at a higher rate than that of some of our other vaccines as far as the risk of anaphylaxis. What had been seen was that there had been some cases initially identified of thrombosis with thrombocytopenia, or TTP, occurring with the chimp adenovirus COVID-19 vaccine, which is the AstraZeneca vaccine. CDC had put out a health alert related to this, and they noted some signal occurring through the vaccine adverse event reporting system with the Janssen vaccine. So there were no cases for Moderna or for Pfizer, importantly, and I think that's a key takeaway point is that there does not seem to be any increased risk despite literally millions of doses when this last analysis was performed, whereas they did see 28 confirmed cases with the Janssen vaccine. So to put that into perspective, there was an increased risk, particularly in females over that of males. It's about 3.2 per million doses administered is what it looks like. It's just starting to settle out at as far as a rate. Again, that puts it into the range of the risk of anaphylaxis from Moderna and Pfizer vaccines, which is very uncommon. Importantly, when there had been this safety hold, what you see is that, as kind of expected, among those that had the various age ranges, we'd already seen a marked decline in terms of vaccine use in those 75 and above and in those 65 and above pre this hold that had happened with the Janssen vaccine. And this is in part because most of the population in these ages that were going to get vaccine had already received vaccine. The concerning thing is that there'd been a marked impact upon those essentially less than 50 years of age. So the three age categories below that, you see a marked fall off in terms of all vaccine use with that happening. And so that I think has been an unfortunate event to happen, shaken some of the vaccine confidence. So to put that risk of the Janssen vaccine, so about 3.2 per million, into context, if we think about the risk of getting struck by lightning per year, that's just under 2 per million. Your risk of being attacked by a shark or dying on a commercial air flight's less than 1 per million. So despite many of us being afraid of those things, those are very, very rare events. Your risk of lightning strike is roughly per year is a little bit less than 2 per million. Janssen risk is a little higher than that of that TTP syndrome. And then by going up by orders of magnitude, this is then the risk, which is of car or influenza related deaths per year, 190 per million. And then the risk of dying of COVID-19 in the past year was about 1,900 per million risk of death. And then 1 in every 10 people had been diagnosed with COVID-19 in the past year. So huge difference in terms of risk associated with the vaccine. An important emerging issue that we clearly need more information about, we have very limited data to date about, is that there may be an increased risk of myocarditis or pericarditis in younger adults and adolescents that receive mRNA vaccines. So this is kind of an emerging issue. CDC has not definitively been able to identify whether there is increased risk, but there may be, particularly with the second dose of vaccine. And particularly it seems in these older adolescents and young adults. In the BEST database, which is the VSD database, which performs active surveillance for these events, has not identified any increased risk, importantly. But this is a kind of active area that we do hope to hear additional information about in the near future. There was recently published just last week by a number of individuals across the country, a case series of 7 cases of myocarditis in adolescents following Pfizer vaccine. In essence, I think the key things from a takeaway standpoint are that these are happening particularly post the second dose, within a few days post second dose, roughly 2 to 4 days post second dose. And universally, they seem to have chest pain in association with that. So that's an important thing to be aware of. And there was a nice editorial by Sean O'Leary and Yvonne Maldonado about, yes, we're seeing potentially some cases, but is this true and actually related to vaccine or not? So much more to hopefully learn about that in the future. This was a slide that I've modified slightly, but in essence had been put together by the Kaiser Family Foundation, a nice study that looked at individuals and their hesitancy towards receipt of vaccine. And you can see that there's a number of individual groups that are either less or more hesitant. But I think one of the key things here is that if you're not approved to receive a vaccine, you're not going to be able to get it. So I inserted that line there. The most hesitant, or those who will definitely not be able to get vaccine, are those for whom it's not licensed. So pregnant women had been a real concern because they were not included in the phase 3 clinical trials of the COVID vaccines. And so there had been a lot of effort to move forward phase 2-3 clinical trials here in the US in pregnant women, in part because the question of do we need a vaccine in pregnant women had initially not been real clear, but data that had been generated actually does demonstrate that there is significant maternal morbidity and even neonatal and infant mortality or fetus mortality that occurs in association with COVID infection in pregnant women. So in this series of cases that was published in MMWR, they looked at pregnant women who were symptomatic in this column, and those that were asymptomatically diagnosed, probably on screening on admission to the hospital. In essence, I think it is helpful in terms of providing some background numbers in those that are asymptomatic on admission. And you can see that I think a key couple of things. One is that they saw several deaths in those that were symptomatic among pregnant women. They also saw preterm birth occurring with a much higher frequency, and pregnancy loss also occurring at a higher frequency than among those that were asymptomatic for COVID on admission. So, and also some neonatal deaths in those that had mothers that were infected with COVID-19. So clearly concerning from the standpoint that we were seeing some evidence suggesting increased perinatal morbidity and mortality. So big issue. From that standpoint, CDC had given a really passive recommendation. The Society for Maternal Fetal Medicine was a little stronger, and then actually ACOG, which is the American College of Obstetricians and Gynecologists, came out actually recommending that COVID-19 vaccine should not be withheld from pregnant individuals who meet the criteria for vaccination based on ACIP recommended priority groups. And in essence, we saw that many healthcare workers who had initial access to vaccine chose to move forward with receiving vaccine. And fortunately, CDC had put together a study using the vSafe database to assess safety and tolerability of the vaccine in pregnant women. And in essence, I think a couple key things from the study that they had done. One is that they saw a little more pain in pregnant women in comparison to the comparator, which is non-pregnant women. Otherwise, the rest of the systemic symptoms were fairly similar between the two groups for both the Moderna and then also for the Pfizer vaccine. So they look very, very similar. And then in terms of the outcomes among those for whom outcome data were available, they saw that the rate of spontaneous abortion, stillbirth, preterm birth, small for gestational age, congenital anomalies, and neonatal deaths, and those infants that had received, vaccine was no higher than the background published incidence of these events occurring. So this has really provided tremendous reassurance about the ability to use vaccines during pregnancy. This has actually impacted many of the vaccine manufacturers' ability to actually move forward with phase 2-3 clinical trials here in the US because it's being given as standard of care. So we'll then shift gears and begin to talk about children. So the initial impression was that children don't transmit virus. I think what has become more clear over the course of time is that children are less frequently symptomatic, and that symptomatology strongly does correlate with the amount of virus that they're carrying in their nasopharynx. And then there is some uncertainty about the impact of school closures in that attempt to decrease the risk of transmission to adults. I think what has become clear is that children do transmit SARS-CoV-2. It's a relatively less frequent event. And so there have been transmissions from a daycare setting, from overnight camps, schools, other settings of children transmitting to other children. Does seem to be higher among your older children than among your younger children, but clearly can happen. I think one of the benefits of school closures and this probably saved us this past winter, is that the school closures school closures and all the masking, social distancing and so forth really dramatically impacted RSV and also influenza. And so at least here in Georgia, hospitals were getting very, very full with COVID right around the turn of the new year and into early January with approaching capacity. But due to the fact that RSV and influenza essentially disappeared, we had sufficient capacity to deal with all of the COVID-19 that was occurring. So we'll then highlight the fact that this initial impression was that children didn't get sick and that there was very infrequent hospitalizations or inadequate deaths to really worry about needing a vaccine for children. And part of this really came from initial data, and I've shown you some earlier in the presentation, but then also this study that was published in JAMA that had documented only 2% of cases of COVID-19 among children. What we've seen here in the US is that the total percentage since the onset of the pandemic is 14%. And then more recently, it's much higher than that as vaccines have become available for adults, where children are now over 20% in increasing of the current cases. We've also seen a substantial burden of hospitalization in children. So this is for context. So for context, with influenza, this was the background rate of hospitalization in those 0 to 4, and then those 5 to 17. And in essence, what you can see is that for COVID-19, since the onset of the pandemic, we're now into the range for both those 5 to 17 and also those 0 to 4 of what we see for annual influenza in any given season. Importantly, those rates are actually much higher than the rates for varicella in the pre-vaccine era. So from a burden standpoint, there's clear justification, I think, in comparison to other viruses for which we have a vaccine. Recently, we're able to publish data about those disease burden in those aged 12 to 17. And I think it does highlight an important fact. If you look at this bottom line, this is the numbers in those essentially 5 to 11 years of age. They do seem to have a lower incidence of disease. In comparison, those 5 to 17 are much more similar to those 0 to 4, where we see a much higher and similar burden of disease in both of those populations. As well, related to that, this is then plotting the incidence of SARS-CoV-2 among children during the typical flu season. And then it compares it to the influenza in 2017, 2018, 2018, 2019, and 2019, 2020. And in essence, these are the epi curves in those adolescents during those years. And you can see that SARS-CoV-2 markedly outstrips influenza in terms of morbidity and hospitalization. So clearly it provides a good bit of justification for moving forward a vaccine in this age population, in essence, 3 times higher than seasonal influenza rates during the 3 most recent seasons. Of course, we're also seeing something called multi-system inflammatory syndrome, which has also been a driver for moving forward a vaccine in kids. Importantly, we've also seen a fair number of COVID-19 related deaths in kids. So these are the pre-vaccine number of deaths per year for varicella, where we're at 50, rubella 17, hepatitis A 3 per year, rotavirus 20 to 60 per year. For influenza in an annual season, it's roughly 119 to about 200 cases per year in children. For COVID-19, since the onset of the pandemic, we're now at 332 kids that have died. So clearly there is actual mortality associated with the virus. Yes, it's much less than that we see with COVID-19 in older adults, but it is absolutely still a relevant pathogen for our kids. As well, there's been substantial non-medical direct impact upon children by COVID-19, marked impact upon this younger generation with online learning, impact upon extracurricular activities, economic impact upon them, emotional and psychological development of our children as well too is at stake. So why do kids need studies? Well, they differ in terms of the height, weight, body surface area, muscle mass, and fat distribution. All of those might well impact the dose needed in children. We do need to understand that reactogenicity, safety, and immunogenicity establish the dose. There was initial argument from many experts saying, well, we can just wait and begin pediatric studies after safety and efficacy data is established in adults. That's actually not accurate at all. I'll mention just a couple of things to just highlight that fact. First is that actually our adult phase 1/2 COVID-19 studies were conducted in parallel with the animal studies. This allowed expediting of the phase 3 clinical trial. They had all the information that they needed in order to provide the EUA, but the fact that they did move forward with human studies in parallel with animal studies really allowed for the adult vaccine to move forward much more quickly, probably by months. Probably preventing hundreds of thousands of deaths at this point in time. From a vaccine development standpoint, they typically start with, for kids, typically starts with a small phase 1 study in healthy young adults. And then phase 2-3 studies usually occur without large studies of adult safety and efficacy. So there have been a large number of pediatric vaccines licensed before there have been substantial adult safety and efficacy data. I've listed some of those below that. Currently, there are multiple live attenuated RSV vaccines in kids with currently very minimal adult data. So many of us had really advocated to move forward a pediatric vaccine in terms of providing direct benefit to kids, potential indirect benefit to the community, addressing some of the safety concerns that might need to be addressed with a vaccine in children, emphasizing that we don't need adult safety and efficacy data before we actually move forward with the clinical trials, and also emphasizing the Pediatric Research Equity Act. Fortunately, we were able to get some support from American Academy of Pediatrics to also emphasize the importance of trying to move forward vaccines, and also NIH had actually done an ethical review of the data, and they also came to the net conclusion published in Pediatrics that in essence, you can begin these clinical trials before efficacy has been demonstrated, can speed up the process of providing access to a safe and effective vaccine in children and their families. So they also came to a similar conclusion that we can move forward with vaccines. Unfortunately, we had seen Pfizer had started with going down to age 16, and then they moved down to age 12. And these are data that were just published about 2 weeks ago. And in essence, I've highlighted with red arrows here, the 12 to 15-year-old group. And you can see that from a local symptom standpoint, the primary symptom similar to the adults is pain at the injection site. For the systemic side effects, they are more frequent with the second dose, and the red arrows highlight where we're over 30% of children in the 12 to 15-year-old age range as far as symptoms. So we see fatigue and headache, particularly with the first dose. That's very similar to the rate of those 16 to 25 years of age. And then with the second dose, we do tend to see more symptoms: fatigue, headache, chills, and muscle pain being most frequent at over 30% of those receiving vaccine. So important to be aware of that. They also looked at the GMTs or the antibody titers among those that have received vaccine. And in essence, you can see that achieve very good antibody titers, actually above the rate the antibody titers generated in those 16 to 25. And they saw 100% efficacy in the Pfizer study. So where do we go from here, and where are we at? So among those 12 to 17, Pfizer issued an initial press release at the end of March. They submitted their data for expansion of their EUA in the 12 to 15-year-olds on April 9th. FDA then approved it about a month after they had expanded the EUA, or about a month after they received the data. It was reviewed within 2 days and approved by ACIP. For Moderna, they had a similar number of children, actually a little bit higher. They also saw a high degree of efficacy in the study. They did note some pain, headache, fatigue, myalgias, and chills, especially with the second dose of vaccine. They've released in press releases portions of their data beginning in May. and then reportedly they had submitted their data for expansion of the EUA in those 12 to 17 years of age the first week of June. So that was last week. So if we extrapolate, that might mean about a month from then we might see FDA review, which would put somewhere right around Independence Day here in the US, give or take a little bit, and then ACIP review occurring several days later. So probably first full week or second full week of July might be likely if they follow a similar timeline to that of Pfizer. So there are ongoing studies now in children less than 12 years of age, and there's 2 trials here going on in the US. These are trials of age de-escalation and dose escalation or dose finding studies. So Pfizer has data, or is beginning their study in the phase 3 component of their study. They've done the dose finding, and they anticipate having data in September for those 5 to 11 years of age. In the very limited press release that we have, in those 2 to 4, it's soon after that, and then maybe October, November for those 6 months to less than 2 years of age. They did note in their press release, which came out yesterday, their dose for the 5 to 11-year-olds is 1/3 of the dose in those adults. And then in those 6 months of age to 4 years of age, they're going with 1/10 of the adult dose. So there is a dose change that'll be happening for Pfizer. Moderna has not stated a timeline for when they're going to have their data, but there is essentially a quote from their CEO who said it'll be early fall as to when they expect they'll have data for Moderna. Janssen, so they have started some small studies in adolescents in Spain and the UK. There's no word of US enrollments. I think things are absolutely going to be impacted by the TTP issue in adults. So it's unclear timeline. And one of the challenges here is that there's kind of a limited window for enrollment of these other vaccine studies before potentially EUA would be provided for another vaccine manufacturer, making other studies impractical or infeasible. Novavax may expand their adult phase 3 study down into teenagers or lower. It's unclear about that. There's some uncertainty about whether the FDA will actually grant EUA for those less than 12 years of age. That is not an absolute certainty that they will necessarily grant EUA. And then there are, of course, practical distribution challenges with many of the vaccines. And then there's ongoing data safety review happening on a regular basis. So one of the key questions is, should a vaccine be considered mandatory for children? There's a nice editorial from Douglas Opel, Doug Diekema, and Laney Ross that essentially went through the ethics of what would be required in order for a vaccine to be mandated in children. From that standpoint, I think the key things here is that they kind of outlined 9 different things that they think that you need kind of answers to in order to decide about moving forward with making a vaccine mandatory. So you need experience with a vaccine containing the antigens, demonstrating it's safe and has acceptable level of adverse events. It needs to be effective. It needs to be cost effective in comparison to other vaccines used to prevent disease. The vaccine containing the antigen should bear some relationship to increasing safety in the school environment. Should contain vaccine containing the antigen preventing disease with significant morbidity and mortality in at least some subset of the population. And then one would ideally want to potentially prevent transmission. Needs to be acceptable in the medical community and the public. And administrative burden needs to be reasonable, and burden for adherence to vaccine strategies needs to be reasonable as well. So that's kind of the framework that they proposed, and I think that that's useful. I don't see a vaccine being mandatory in children in the near future. We first need to just get the vaccines forward all the way through to a EUA, and then ultimately a BLA, and then I think discussions will be ongoing about whether or not they should be considered as a mandatory thing. So the search for a vaccine does continue on for COVID-19. We've made tremendous progress. We're in great shape in comparison to where we were a year ago at this time. And yet we've still got a ways to go to have vaccine available for all populations of people, including our children. So happy to take questions at this point.
Yeah, thank you so much, Dr. Anderson. That was a fantastic presentation, and I can see here there are a lot of questions. So clearly, you sparked a lot of interest. As I try to triage these questions, I wanted to start with one of my own. The myocarditis issue seems to have been generating a lot of interest or concern in the past week or so. And I've seen the case report of the seven young boys, 7 young men. Is there any idea if the myocarditis incidence in the U.S. are we getting? Is it appear to be similar or in the same ballpark as Israel, where I think it was 200-300 patients out of 5 million? Does that seem to be what we're looking at roughly? And how are we tracking the incidence, and how are we going to know if we're seeing more than that?
Yeah, so great question. So from that standpoint, I think we don't have enough data, or at least it hasn't been announced as to what we're seeing as far as an incidence. The vaccine adverse event reporting system is a fairly useful system for identifying these rare events, particularly when coupled with any mention of this in the public, where the public is aware of it. The vaccine event reporting system is actually very good at capturing nearly all of these events that occur, because in general, if it's in close association with the receipt of the vaccine, people do tend to report, although not 100%. And so the VAERS system is actively monitoring that. I expect that there will be some updates about that over the upcoming probably weeks, and particularly as we move towards the next ACIP meeting. In addition, though, I think really to get the best answer about increased incidence will be the vaccine safety data link, where they can look at essentially control on a much better basis for active cases among those that receive vaccine versus those that don't, and control for some of the other things that might predispose one for myocarditis or pericarditis, and get a much better answer. In that data, they haven't seen any increased incidence, but that data kind of accumulates more slowly.
Thanks. We had some questions about messaging for patients who are concerned about fertility and the vaccine. And I know this seems to be a story that just won't go away. What do you recommend we say patients regarding fertility and vaccines?
Yeah, there's really been not any evidence to suggest that any of the vaccines are associated with any fertility issues. And that is one of these social media challenges that I think we're increasingly facing in medicine, where something gets generated in social media and then you see others pile on without any evidence to demonstrate as much. Hopefully there will be data about that coming out in the future. Timeline for that is a little uncertain, but I think the key thing right now is just there's no evidence to really support that from a data standpoint.
Yeah. And staying in the maternal fetal health realm, some people were asking about breastfeeding. I think I know the answer about safety is yes, absolutely, it's safe. Somebody was asking about antibodies passing from vaccinated individuals to babies.
Yeah, it's a great question. So we and others actually have ongoing studies trying to look at that issue among women that have recently delivered, to try and look at what are those antibody titers and what do those antibody titers, what are the components of those antibody titers, because one antibody is clearly not the same as another. And so we do hope that there will be some additional data coming out about that issue in the not too distant future. I think the key thing there is that by vaccinating mom, you're taking a key member who may be very important in terms of exposing the infant to risk, that being the mother, and essentially decreasing her risk of COVID-19 substantially, which is going to be critical in terms of protecting the infant.
Thanks. A question about anaphylaxis. Clearly, as you demonstrated, it's extremely rare. If somebody had, an anaphylactic reaction to Pfizer, say their first one, what would be the recommendation regarding getting, say, a Janssen vaccine, and how long to wait?
Yeah, great question. So if you've had trouble, like anaphylactic reaction to an mRNA vaccine, it's not recommended to use another mRNA vaccine. Janssen is feasible. There have not been much data to kind of support safety and efficacy and timing for kind of shifting over to a different platform for vaccine administration. And we do hope that CDC will have more actual data to inform decisions about that. But right now, it's pretty much expert opinion.
Yeah, and is there any information out there about the Janssen J&J vaccine on the Delta variant?
Yeah, right now, I'm not aware of any data for the Janssen vaccine and its ability to prevent the Delta variant, either in patients that receive vaccine or in the laboratory. A lot of the data that I presented was really laboratory-based, where we do see a roughly 7-fold decrease in terms of the antibody neutralizing titer in those that have received vaccine. But we don't know similar data with the Janssen vaccine, although these are critically important questions that people are working really hard on to try and get us some actual data to inform making decisions.
Great. Yes, and you talked about vaccines to variants being in development as we speak, and you talked about the long half-life of antibody responses to vaccines. So with that in mind, how likely are we to have a need for a booster vaccine? When would that be, if so, and would it be, would they be trying to target a variant or a group of variants, or would it be one shot? Would it be 2 shots? What do we know about that?
Yeah, I'll answer the easiest part of that one first. It looks like it would be 1 dose of vaccine that would be needed. Really, that 2 dose with the initial series is to prime the immune system and then boost the immune response. Once that immune response is in, even if it's declined over the course of time, a single dose is anticipated to be sufficient to result in a good immune response. And Moderna had made a public announcement about some data, essentially their data, that they were seeing good responses after a single boost dose of vaccine. The dose that will be needed may be lower than that with the original dosing. That is a question that still needs to be in part answered. And then the timing of a boost vaccine and the need for a boost vaccine is a question that is, I think, paramount in this field right now. Partly it's being driven by the fact that we still have not been able to establish the correlate of protection. If we can establish that correlate of protection from the phase 3 clinical trials, that'll be really critical, because that data can then be used to compare antibodies in those that receive vaccine over the course of time and actually determine when people are going to start to be at increased risk of actual infection again, based off of their rate of antibody decay. So we do anticipate that there would be data about that correlate of protection coming in the next months. That will be absolutely critical in terms of answering this question. In the meanwhile, it's kind of educated guesses. Pfizer has said that that they do think they'll need a boost by a year out from their initial doses of vaccine, but there's been really very little durability data presented publicly about their durability. For Moderna, there has not been a similar statement from the company about that question. And based off of the data that are published, which are a bit more extensive, still suggests that we're seeing really good antibody titers out 6 months or even longer. So I'm not sure that a year is going to, I'm not sure that a year would be necessarily needed, but we'll have to wait and see about that. It does appear that a boost may provide some cross protection against the variants, importantly. So, I think it probably won't be close to a year until anybody gets boosted as in actual outside of a clinical trial setting, and then dose will be a key question, and if it's actually needed is another key question that at the moment, I think there's still a lot of question marks about.
Yeah, thank you. And we actually had a few people asking about getting an mRNA vaccine after a single dose of AstraZeneca. And I guess that would be in the context of somebody who had returned, from living somewhere internationally and coming back to the States in between their two vaccines.
Yeah, so there's not good data to my knowledge about that specific question. I think that there are a number of studies that are going on, particularly internationally, to try and begin to address that question, because that is a critical question for the world, in essence, about the safety and immune response observed with that kind of mixing and matching between the vaccine platforms.
Yeah. Thank you. I'm looking through these now. Paul, did you have any questions you wanted to ask Ziad? Trying to see that we've hit all the themes that were asked about in our Q&A.
Yeah, Andrew, I'd like to ask a couple of questions, Dr. Anderson. I'm actually in Beirut and in Lebanon right now. Sputnik 5, the Russian-made vaccine, which is an adenovirus vaccine, is being administered. People are asking about that vaccine. That's my first question. And my second question would be, since this is an adenovirus vaccine, do we expect to have potentially some of the thrombosis, thrombocytopenia, rare events that have occurred with the Janssen vaccine? And why is that these happen in these type of vaccines? Thank you.
Yeah, great question. So, the initial descriptions of this thrombosis with thrombocytopenia were with the AstraZeneca vaccine, as you mentioned, and then which is a chimp adenovirus vaccine, and then we're also observed with the Janssen vaccine, which is adeno 26 vectored vaccine. So that really raises the question of whether adenoviruses in general may be associated with this thrombosis with thrombocytopenia. That is a important question because Sputnik 5 is a mix between several different adenoviruses. So it is, I think at present, I think it's reasonable to say it's probably more likely than not that we might well see that with Sputnik 5. And with the whole platform of adenovirus vaccines. And so there definitely does need to be some caution about that. I don't anticipate Sputnik 5 moving forward in the US. I think that it will continue to be a relevant presence internationally. And it is an important thing for providers to be aware of as a potential issue with the Sputnik 5. One of the challenges, I think, with Sputnik 5 and with some of the other international vaccines is that they haven't gone through some of the same clear steps with the same reporting mechanisms that are needed in order to really understand the data. That is an issue. I would encourage international manufacturers to be going through the WHO pre-qualification process. I think that and trying to ensure that they're following GCP and other general guidances because that is actually critical in terms of being able to trust and rely upon the data that are coming out of these clinical trials.
Thank you. Paul?
Yeah, hi. Thanks again for just an outstanding presentation. I have three questions. The first one is about patients with some sort of immunocompromised condition. As I think you mentioned and others have reported, particularly patients on transplant, who've undergone transplant, they're not getting the response that we'd hoped for. What are the longer term implications for management of patients who are severely immunocompromised if they don't provide the proper immunogenicity to the vaccine? I guess it's the first part of the question. And then those with less compromised immunities, such as those with RA, for instance, have we seen any differences in their reactivity after the vaccine?
Yeah, so yeah, absolutely. There has been this question raised, particularly in the transplant population, and particularly with medications like Program, cyclosporin, and others, and as well some question about some of the other immune modulators, particularly rituximab, and its potential impact upon the ability to generate an immune response after COVID vaccination. So I think a key thing is, again, really understanding what that correlate of protection is. We think it'll be an antibody. We think it might be a neutralizing antibody, but we don't know. If we can identify that, that will give us a better idea of what we need to actually aim for in our transplant and our RA populations and in others, where we would have a sense that they might be protected. I think in the meanwhile, a key thing is for them to be to ensure that those around them are receiving COVID vaccination, and trying to make sure that their family members and those that they're in closest contact with have received COVID vaccination, because it is that household transmission which is critically important in terms of much of the transmission of COVID-19 in the recent past. So I think that's a key point to make. I think that there will be, or there actually are, a number of studies starting in the transplant population that will begin to answer that and these and other questions that I think are going to be really critically important to knowing, do you need an extra dose? Do you need a higher dose of vaccine? Is it that actually that although we don't see great antibody responses, they're still protected? That's a possibility, because protection is a little more complex sometimes than we boil it down to when we look at just antibodies. So I think there's a lot more to be understood on that issue, and hopefully we'll have a better sense in the next months.
Okay, great, thank you. My second question is regarding vaccine hesitancy, which is worrisome certainly, and whether it's predominantly based on people's fears about adverse events of the vaccine or other factors as well. And how do you counsel patients or families who have such a belief, even those who might have received, might have come down with COVID and have refused the vaccination? Do you have any, counseling recommendations to providers about how to, work through the hesitancy of their patients?
Yeah, so I think really understanding what's driving that hesitancy is critical, because sometimes we do a really good job of answering the wrong question, or answering the wrong reason for why people are hesitant. And that hesitancy can look like a wide variety of different things. It can be misinformation. It can be fears of fertility, fears of crazy things like because it's an MRNA vaccine that could incorporate into the DNA, things like that have no scientific basis. So first understanding what the issue is the first key step towards then beginning to address the hesitancy issue. Then I do think, and this is going to be increasingly important, this is going to be critical for those on the ground, those that are in the rooms with the patients, to be and with their ongoing patients with ongoing relationships to be advocating for vaccine is going to be critical in terms of overcoming that hesitancy. There's a ton of data in pediatrics that if the pediatrician is the one who's having the conversation and advocating for vaccine, the parents are then willing to move from being hesitant into actually receiving vaccine. So it's key things, I think, like that will be important going forward.
Great, thank you. And my last question, you mentioned, the dramatic drop off in RSV and seasonal influenza and probably the common cold as well. Dramatic, these are, observations that we haven't had any, precedent for in the past, to see the response to masking and the dramatic drop off in these other infectious processes. As a pediatrician and a researcher, what are some lessons learned for the future? Is there going to be a role for ongoing masking? Are there things that we will need to adapt to so we can prevent other infections, beyond SARS-CoV-2, based on what we've experienced over the last year?
Yeah, so that's a great question. I think that probably the declines seen in pediatrics were multifactorial. So it was in terms of RSV and in terms of influenza, it's partly the changes in schools, it's the changes in social distancing, mask wearing, and remote learning, hand washing, that have all had substantial impact upon COVID-19. Not only on COVID-19, but also on influenza and RSV. There is not a lot of political will to continue to wear masks. And I think as a population here in the US, it is very hard for most people to continue to want to wear a mask. And I think we've seen that with the loosening of restrictions. And then you see everybody stop discontinuing mask wearing, even those that are unvaccinated. And we're a population that's a little slow to learn and to really follow public health guidance. So I don't think on a big scale that it will be that we'll see masks worn on a large scale, but I think particularly those that are immunocompromised, those that are in a healthcare settings, I think we're going to see masks being worn on a much greater scale and with much more frequency. And we will be seeing people going to the grocery store and still wearing masks in the future. And I think that will be a real change that happens and probably will impact burden of disease, flu and RSV. But I think on a population basis, it's going to be hard to continue the masks long term.
Yeah, so certainly after SARS in China, there were folks from that part of the world that continued to wear masks. And I recently came into New York just this past week, and still lots of mask wearing on the street. It's really striking. Andrew or Ziad, any last questions you'd like to get to?
Not for me, thank you.
Same here. Thanks again.
Well, I'd like to again thank Dr. Anderson for a superb presentation, great Q&A. Thanks, Andrew, for moderating the Q&A today, and Ziad, much appreciated. If we could go to the next slide, please. So we'll be continuing this webinar series, not weekly, but over the next several months, we'll still provide some webinars as we wrap up the series. And the next webinar will be on vaccine passports, which is an interesting phenomena, which is first starting to get discussed. And we'll have a speaker actually from overseas in the EU, where vaccine passport discussions are perhaps further ahead than they are in the US, discuss the concept of vaccine passports. And we'll have an update from Malta, where they have much experience with this. And that's on June 23rd in 2 weeks at 3 p.m. Eastern time. Next slide. And our prospectus, which summarizes all these webinars over the last 15 months or so, can be found on our website. Thanks again for the presentation, Dr. Anderson. It was really wonderful.